Tech, it could be Cerner. Those are the top three in the market right now. It doesn't really matter. I'll talk about why we chose Epic, but it could be anything. As part of your project management, you'll learn about change management. That's a big deal, right? And so I'll show you a couple of graphs that talk about that change curve and how it played out in our hospital. And then I'll talk about some of the lessons learned. Stop me at any time if you have any questions, if you don't understand anything. I want this to be interactive, so if there's something that doesn't make sense, I lived and breathed this stuff for many years. I'm no longer the CIO at the Ottawa Hospital. I'm the executive officer at OCIN, which is Ontario Clinical Imaging Network. But essentially what we do is we collect all of the imaging in Ontario, put it in a central place, and then when patients move around, it's distributed and sent to whoever needs it. So centralization, like a brokerage for medical imaging. Okay, so let me tell you about the Ottawa Hospital. So the Ottawa Hospital is a merger of three different hospitals. It merged in the early 2000s, and you can see the history, but three very large campuses. I'll go through this stuff quickly. At the time, you can see the number of beds. When you talk about hospitals, typically, the way they measure how big they are is how many beds do they have. Right? It's typically not revenue-based. In the US, it's revenue-based. In Canada, we talk about you can see the satellite locations, 4.5 million square feet, 175,000 emergency visits per year. That's probably in the top three in Canada. So a lot of emergent visits. And then over 1 million ambulatory care visits. That's clinics, non-hospital, non-bed clinics, over 1 million, which is a lot. That's probably the highest. At the time, the Ottawa Hospital had a strategic vision, okay? And this is important because it had a goal as part of its vision. So, the vision was very clear. Treat every patient like they were a loved one. Very simple, all 15,000 people could actually understand, right? So if that was your grandmother coming in, or if that was your dad, if that was your child or sibling, how would you want that treated? Every patient should be treated. The goal was to be a top 10 performer in quality and safety in North America. This is important because we could have said Canada. We didn't. The two systems are very different. With profit generation in the US is paramount. They can afford a lot more. But we said North America because we wanted to be compared with the best of the best, which in fact was at the time the US. The middle part is what's called the quadruple aim. If you ever look up quadruple aim online, there's so much written about it, but most healthcare systems have a quadruple aim, right? So better patient experience, improved staff work life, better quality at less cost, and healthier populations. That is consistent pretty much in every healthcare organization, as in terms of an overall goal. And then you can see the directions. You can see technology is an enabler. That's important. So technology isn't a goal or the ends to a mean. It just enables you to get to the top. Okay. 3 parts of the Ottawa Hospital. Patient care, obviously paramount. Education, you saw how many thousands of fellows and medical students and nursing students and system, I have to incorporate all of these things, which is what I'm telling you about it. So here's the research part. You can see it was one of the highest ranking. Research is based on how many publications and how much funding you got. It was consistently ranked in the top 3 in Canada. You can see the number of residents. That's a lot of people that go through. And remember, a medical student will only be there for a few years, and then they change, and a new cohort comes in every year. So you have to account for that. Okay. So this is a story from 2014, which is when we started. This is when I joined the Ottawa Hospital. Prior to that, I was in the private sector. So I was running companies before that, mostly small to mid-sized companies. And for the life of me, I have no idea why I left the private sector to go work for the public sector. Some called me very crazy. My wife is a physician. That had a lot to do with it. I enjoyed learning about healthcare, and I actually thought I could make a difference. And probably one of the best decisions I made, right? Very meaningful work. So this is kind of what, yeah, go ahead.
I just want to ask, was the Ottawa hospital system one of the first in Ontario to make the switch to Epic?
It was the third. Yeah. The first one was CHEO in Ottawa. The second one, in a large way, was Mackenzie Health, which is north of Toronto in Vaughan, and then we went. In fact, I would say Sick Kids probably was around the same time. They may have beat us. We may have been the fourth. And then Trillium in Toronto went right after us. And then St. Joe's, and now almost everyone's coming. So we did an analysis in 2014 that said, okay, what's happening in the market? Like, if we want to be top 10, what are the top 10 hospitals in North America doing? Because what we were doing was we had bought a system, and then we had actually developed our own software to put on top of that system. So we had a bastardized system that we had to maintain. The companies I ran before joining the hospital, two of them were software development companies. If anybody would have wanted to get into the software development business, it would have been me. But there's one thing I know for sure: no hospital should ever be in the software development business. Ever. Because there's no revenue stream, right? You're not going to sell the software. The revenue stream allows you to maintain it and update it and upgrade it. And you know, we didn't have that. So nobody should be building software. That's not in the software development business. Anyway, if you look up the Ottawa Hospital 2010, 2012, they were on the front of a whole bunch of magazines. They were the first hospital to get 4,000 iPads to all of their docs. They called it patient care at the bedside. And that was the software that was built. It allowed the docs to actually, remember, this is 2014. It was revolutionary back then, right? Imagine having all your test results right on the iPad at the bedside instead of on paper. Very cool stuff. Should never have been done, right? Because it was cool for about 2 years. And then maintaining it got way too expensive. That's the problem. So don't buy into cool factors, right? Think sustainability over the long term. You know, it's different based on what business you're in. If you are a startup that's looking to sell in 3 years, great, cool factor is really good. I've done it before. I've run companies that cool factor was everything. But a hospital that has to be around forever, cool factor doesn't mean much. So this is what was happening in the marketplace. And this is what I told the board. I said, listen, if we want to be like some of these guys, they're all moving. They're moving away from these best of breed systems to a best in class, all in one consolidated system. That's what's happening in the marketplace. This was our 5-year strategic plan in IT plan in 2014, and as I said, we had budgeted about $120 million for a new HIS, hospital or health information system. We had a plan, so this is not like just buying a computer, right? You gotta go talk to everybody. This is the hardest thing in healthcare. It was probably the hardest thing for me going from private sector where you just made a decision because it was the right decision and it made sense. But in healthcare, you have to get consensus and you have to get people on board. Otherwise they won't change. It's frustrating as hell, right? But what I've learned over the last, I don't know how long, 11 years in healthcare, it's actually the right thing to do and it's necessary because of the business we're in, right? So I was humbled. So we built a plan. We said, okay, this is kind of how long it's going to take through sort of the TCO analysis, financials, really important. Get the CFO on board, get the COO on board. Go talk to the CEO, get the senior management team on board, get everybody on board, and then go outside. I don't know if you guys were around when the LHINs were around, local health integration networks. They were in charge of the 25 hospitals in Ottawa. It was our LHIN, it was 14 LHINs in Ontario. So we had to go visit them to say, hey, look, we're doing this, we're the biggest hospital in the region. Maybe somebody wants to join us, right? So that was that conversation. And then you got to get legal and procurement involved, and it's an ordeal. That's like a 2-year time horizon. So remember I talked about the why, right? So when I go to the board, when I go to senior management, there was a lot of reasons why. And what I learned after doing this presentation is people don't, like, this is too complex, even though it's all right, okay? So if you look at it, we want to be top 10. Every top 10 organization in North America has either an Epic or a Cerner or a Meta. And the reasons behind it are all of these. If you think of healthcare funding in Ontario, think of a pie, and everybody gets a little slice of the pie based on how big you are. The size of the pie never changes, right? Very rarely does it change. And so, how do you get a bigger piece of the pie, right? You can see more patients, hard to do because you're already maxed out. Because everything's about how many patients do you see, what type of cases do you have. So what we learned over sort of the 3 years that we started this is that Ontario was actually changing their funding formula, whereby if you could actually show them data, they would give you more money based on that data, right? So cost per case was a big issue, throughput was a big issue, cost per bed was a big issue. And if you think about what systems you need in place to actually measure that, you need a lot of horsepower to figure out what is the cost per case. And so what we figured is that the better we would be able to do that, the more information we could provide the ministry, the more funding we would get. There was a real straight line correlation. In the business world, you would say we would increase our revenue, right? In public sector, you would say we'd get more funding. Same thing. Okay, most people didn't know this about the Ottawa Hospital, but what I was shocked about when I got to the Ottawa Hospital is that the systems we were running were 25 years old. Okay, so I had a hard time explaining this to the board, and I remember two specific presentations, because they would say to me, Shafiq, we're in like 2015. I can go to my dentist and they can tell me if there's an opening, and they could text me, and I could take that opening. I get information on my mobile phone from my dentist, but from the hospital, it comes in the mail. Like, what the heck, Shafiq? Like, you know, we're supposed to be this big bad hospital that's got all these iPads, and we're supposed to be really cool. So I had to explain to them that our systems, the way that when they were installed, there actually was no internet. That concept was lost on them, right? So to take a system that was built during a time when the internet didn't even exist and make it do things that in today's world are normal, it's almost impossible. Or if you could do it, it costs twice as much. So the idea was they needed to get their head around the fact that we're still running 25-year-old systems, right? Like, mobile phones weren't around when we put this system in. So to try and make it work with a mobile phone, you have to start putting in intermediary systems so that it can talk to the phone and it can talk to the system and translate. When I say those things, think money, 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 right? Money, maintenance, upkeep, upgrades. It would be an absolute mess. Better to just change it up. The third thing that I told them is, because they're in healthcare, so I had to bring a healthcare analogy. I said our systems are on life support, right? They're on life support. It's a dying patient. It's going to die. We don't know when, but it is going to die, and sooner than we think. So we can either do something now, or we can wait until the patient dies and then scramble like hell to try and make it happen. So I think they got my message, and I did get approval ultimately. The other thing was quality and safety and corporate risk was a big item. We had an enterprise risk management system, and you guys probably talk about risk quite a bit. And we actually went through all the risk items for the hospital and showed very clearly that 13 of the, I think there was 21 risks, 13 of them, sorry, 10 of the 13 would be addressed by putting in the system. And then quality and safety, like, it goes without saying we want it to be one of the best in quality and safety. So if I go through this with you, you can actually understand, like, and there's a lot behind this. The challenge was, and this is for all of you doing presentations, is this is way too complex for a board. They kind of wouldn't get it, right? So we had to really simplify it down, right? And the power of 3 is really important. Just 3 things you have to worry about, right? You have to worry about improved performance in data, modernizing systems, and becoming a high-performing hospital. That's it, right? Make it simple. And then you can talk about all of the other things that I just talked about in the previous slides. And they'll get it. They'll attach quality and safety to performance of data. They'll attach old systems that are archaic to high-performing hospitals that are modernizing systems. So that's just a little bit on presentation style. Okay, when I talk about an HIS, what is it? Most people didn't actually know what it was. They didn't understand. The HIS actually has all of these components in one system. That's really important because, as you'll see later, a number of these things that are normal in an enterprise, we actually had separate systems to do them. But when you buy one of these, it actually comes all in one. We had our own HRIS, HR information system, and we had our own finance system. Those are very large systems running very large, complex organizations. So we decided to actually not purchase the HR and finance pieces of the whole HIS, because that would have been way too complex of an implementation. But anything that was clinical, we said, we're going to do it. It's all, everything clinical, we're going to buy it. And then the TCO, right? What is it gonna cost? And when you do a proper TCO, you actually have to look at all components. You have to look at the resources. Probably the highest component of any large enterprise cost is resources. Technology, of course, data, project costs, operational costs, and then the other things. Most of the, in fact, all of the systems we were looking at were US based. And so all of a sudden your foreign currency becomes really important. So we looked at everything inside out, upside down. Yeah.
On the previous slide,
Yeah.
I have questions on
Sure.
the MIs.
Sure.
Why did you separate the MIs apart from the hospital system you are acquiring?
Yeah.
Are you saying your existing MIS is good enough to integrate with the new?
Yeah, that's a really good question. So when we actually did our analysis on all of those components, what we found out is that for both of those, most of the HIS vendors actually integrate with third parties. They actually don't build their own, right? So we said, well, if we're gonna need to integrate anyway, we may as well just integrate with whatever we have. That was number one. Number two, the cost was, like, the 120 was only based on everything else. If we had to change the ERP system as well as the HRIS system, it would have been almost double, right? So we said, look, if we're gonna do this and have a chance of success, why don't we just leave those two? They weren't bad, right? And when I have to go to the board and actually say it's gonna improve healthcare, I didn't need to, right? I said, okay, we'll just, and the HRIS for us was, at the time, 7 years old. And we had Oracle for our finance system. It was 10 years old, so. Yeah, good question. Okay, so TCO, very complex, yeah.
That's really, just like, when
Yeah.
you're talking about costs, when you're talking to the board.
Yes.
Also present that, like, what's the cost of not switching?
Yes, yes. Hold that thought, as it's coming up. Oh, here we go. Okay. So, we gave them some options. We said, here's what happens if you do nothing. Here's the cost of not doing anything. We could actually keep our system. We just build and borrow and buy pieces and parts. So we looked at sort of what happens in these criteria that we put together. And then what happens in an enterprise, a proper enterprise system. And then with that, we actually broke it down into two components. One was Big Bang, all campuses, everyone, all patients, all doctors, all nurses, everyone go together one shot, ambulatory care, inpatient, everyone. Or we could sort of do one campus at a time, one module at a time, do inpatient first, then ambulatory care, and go through that process. So we did that analysis as well. And I'm going through this quickly, there's a lot to go through, but bear with me. And again, stop me. I appreciate the questions. And then, oh yeah.
Did Epic help? Like, not at all? It was just whatever.
Because we didn't know it was gonna be
You
Epic.
didn't know it was gonna be
Right? At this point, we just said we're going to market, we're gonna buy the best one that we can find. But this is kind of our internal review problem. We have to talk to a lot of people to figure out all of this stuff. This was sort of the humbling, where are we analysis. It's called a heat map. And we looked at every single system that was in our infrastructure. And we did an honest to goodness, how does it work today? Is it really good? Green? Is it okay, manageable? Yellow? Or is it on life support? Red? Yes?
When you showed the heat map
Yeah.
to, like, not just to the board, but
Yes.
other people around the hospital,
Yeah.
is that when some people started to get why you wanted to get a new system?
Yeah.
Because there's not a lot of green there.
No, there's not a lot of green. I think it was a number of things. This was very revealing, right? Because people didn't know. When you're in it, when you're in the forest, you can't see the trees. And people just didn't know, they just lived with whatever they had, right? And they complained, and they got frustrated. And then they went to they talked to their friends, and they said, you mean you have to do that over, there's like 14 systems you have to do to get. So they were frustrated, they just didn't know why. And it wasn't until we came back and said, look, we're in trouble, right? It's pieces, like, there's some things that just are not working. And the ones that are without color, we didn't include in our TCO, so we didn't yeah.
How did you determine, like, oh, this is a red, this is an orange? Is it like
Great.
data driven? Is it like staff feedback? Like, how did you come?
Yeah, really, really good question. We actually had to bring in a third party to review that had some expertise. And they actually showed us, like, if you've got a proper registration system, these are the components that it includes, and this is how it works. Your registration system doesn't look that spec.
It's easier for someone else to say, this is what you're doing bad, than
Exactly.
you looking at it.
Because they know, right? We wouldn't know any better because we've lived with this. In fact, my team built it. So they think it's the best thing ever.
Proud of it, yeah.
Right? So that was one of the hardest things for this slide, was to actually show it to my team. Remember, I inherited that team, but that's the team that built the old system. So that was a big pill to swallow. Yeah,
Can you disclose the company that helped you build this?
Deloitte.
They do a lot.
Yeah. Won't tell them I told you.
Sorry, I just,
Yeah.
but do look on LinkedIn to see who works at Deloitte. Check out their website, see if they have jobs or co-op or anything like that.
Great, a great organization. Yeah. Deloitte, KPMG, EY, PwC. Great organization. Okay, so very sobering, very humbling. This is a reality check.
Sorry, everyone, please don't start talking about co-op, just
Yes.
listen to me, we can talk about co-op later.
Most of you in IT will know this, but this is really hard for IT people to recognize. Especially if you built it, or you installed it, or you bought it, and you made the decision 5 years ago, 10 years ago, whatever it was. And then somebody's telling you it sucks. Really? So yeah, really hard. This is just to show you some of the complexity involved, right? Like, when you draw boxes, you don't really realize, but then when you draw an architectural diagram, you're like, oh my God, this is spaghetti, right? Each one of those has its own operating system that gets upgraded. So remember, you have to upgrade this piece. That means everything that it touches needs to be tested. So when we upgraded that system, for example, which was our patient record system, it was on an SMS, that was 18 months to do one upgrade. And here's why. It's because you have to test every other system that it touches, right? And that goes with every other system as well. So the complexity was crazy. 35 years old, 25 years old, right? You don't need to say anything. Like, this is in 2015, right? If we were still on it, like, you know, when I graduated, I graduated from McMaster University with a computer engineering degree. I never thought that I would be working on a mainframe, ever, right? I was on a mainframe. So, never say never. Okay, so where does the money go? before I show you the money. Do you remember the enterprise I talked to you about? Do we do big bang, everybody all at once? Or do we do campus by campus or module by module, department by department? And so we did the analysis, and you can see the difference in cost. Right? It's an absolutely easy decision. Right? Forget the cost. Can you imagine for 9 years somebody living through change after change after change after change? Right? Brutal. And what actually really did it for me was we spoke to University of Texas, and they had actually done the piecemeal. They were very early adopters. And what they told me is that they reached a point in time where they were running new on half of their campuses and half of their systems and old on the other half. And they couldn't figure out what the source of truth was for patient information. Right? You can imagine the safety issues associated. If you don't know where the truth is, you're screwed, right? So, as soon as I heard that, I was like, it actually doesn't matter. Big bang. I know it's gonna be hard and everybody's gonna be really, pinchy and whatever, like, doesn't matter. I don't want, in 3 years from now, a safety issue because of a system. Let's just do it and get it over with. If you actually take all these costs and you look at the 10-year TCO, only 23% of the cost actually goes to the vendor over 10 years, right? The rest of the cost, mostly just people, right? So we needed doctors, we needed nurses, we needed people to implement, people to teach, people to, do all of my IT staff needed to be working on this project. So what happens is their costs go to this project cost, and it gets capitalized under the project cost so that the finance people can write it off over 10 years. Makes a lot of sense. But is that really cost? I don't know, okay? I mean, it is, because I had to replace the IT people for, 3 years while we were going through this. This is really important for you to know. When somebody tells you a TCO, how much is the vendor actually getting? And that's pretty typical of very large enterprise system implementations. Okay. How do we figure all this out, and how do we get to the value? I haven't talked about value, I've just talked to you about the numbers, right? So we did a lot of review of literature to say, okay, what did you, what's the clinical value, what's the value in investment, how do you come up with, what do you get out of this system? Yeah.
On the previous slide where you were coming up with the cost, you said earlier that you had not picked out a product that you were going to use. So what did you use to arrive at this number?
What did we use to
What
get?
product did you use? Because you said that at this point you had not decided on the product.
Yeah, this is actually based on other implementations, right? So we looked at, 10 or 12 different implementations across North America. Both Cerner and Epic, they were the most expensive. We looked at one Meditech side as well, and we got the information again from consultants, and then we validated against it. They're budgetary numbers, like we don't know the real cost, right? So there's a lot of buffer in here for sure, right? Because remember, I had budgeted 120 million, this is gonna be 132, right? So there's a little bit of padding in here for sure, because we didn't know, we didn't have access to those numbers. But as it turned out, we came pretty close. Yeah. It's a good question, because you don't know. But when you go to RFP, you have to go with a number, because if they come back with a higher number, you cannot implement, right? So, hardest part of this whole thing is to guess how much is it gonna cost, right? And most of the time, there's enough people that have done it before that you can get a pretty good idea. So to figure out what the benefits are and what the value is, we did a lot of research. We did a lot of understanding of what is our current state clinically. What are doctors dealing with and what are nurses dealing with? If you saw the first part of this presentation, you'd say, this is a CIO from any company, doesn't matter. What really counts is healthcare, right? That's our business. That's our core business, it's patients. So what is this gonna do for patients and clinicians across the organization? So we did a current state on what clinicians are dealing with. And then we did the hardest thing of this whole thing, this whole project, is coming up with an ROI. Because the minute you actually put the number on a slide, somebody is gonna come back to you and say, where is my savings? So you have to figure this out very carefully and very quietly, because the reason I actually took out the individual numbers is there's people in there, right? So these are people that are gonna lose their jobs. So you do not do this lightly, right? Now, in our case, we were lucky. We had people leaving, and so we just didn't replace. And we did a very conscientious exercise to retrain a lot of these people so they could get jobs elsewhere in the organization. When you're an organization that's 15,000 people, that's a lot easier to do than if you're 200 people, right? So we were lucky. Most of these people either left on their own or were redirected to internal jobs. Lucky. That's why it took 2 years. We had to figure all of that out, right? So I put this number up, and sure enough, every board member wrote it down. Because they were gonna come back to me and say, and this is annual savings, right? So if you're a math major and you're trying to figure it out, right? Like, okay, $120 million, $9 million a year, ROI 13 years, something like that. As it turned out, right, we were conservative. We actually hit 10 million in the first year. So unheard of, absolutely unheard of. We were lucky, and part of it was we were good, part of it was very lucky. One of the biggest jokes I had in healthcare, when I joined the hospital, remember, private sector to public sector, I used to joke, people in healthcare don't know how to spell ROI. Because there was nobody talking about it. We need this system because it's good for our patients. Let's go. Right? You'll hear that a lot. Don't fall into the trap. ROIs are really critical. If you don't think healthcare is a business, you're wrong. Okay? It is an absolute business. It is even in Canada, right? I know elsewhere in every other almost every other country, it is a business, but in Canada, they don't think of it as a business. It is a business. And you have to treat it as such.
Most of government now, they do it like that. They're thinking about the government as a business.
Yes.
Yeah.
They need to. They
Yeah.
have to. There's no other way,
Yeah.
right? Money in, money out. It's a business, right? Whether the money comes from taxes or sales of goods or, funding, doesn't matter. All right, so we went, yes.
Irrespective of whether it's business or not, in the ROI, are we talking anything apart from the money? So that public hospital needs to be considerate for that number.
Yeah, hold that thought. The answer is yes. But it depends who you speak to, right? If you're speaking to the CFO, money is all she wants to know. She's not listening to, oh, but our patients are gonna be better, and our clinicians are gonna be happier. We're gonna be able to recruit the best of all clinicians anywhere, because they're gonna work with the best systems and best data. The CFO hasn't heard any of that, okay? We're gonna reduce VAT rates, we're gonna reduce falls, we're gonna reduce medication errors. It means nothing, okay? We're gonna save $10 million, now you're talking. Right? So it depends who you talk to. The CEO will listen to all components. The chief of staff will listen to all the clinical pieces, right? All the nursing. So you have to change your approach based on who you're talking to. The board will listen to all. All right, value on investment, right? So this is kind of where, I mean, we had a 50-page document that talked about all the value, and I sort of took out the pieces that I thought would resonate. All of this, if you're a healthcare person, means a lot to you, right? Like ultimately, when the board asked the question to the chief of staff said, okay, what all of this means is that you're gonna save lives. Is it worth it? How much is a life worth, right? So to him, he was just thinking, how are my patients gonna benefit? Because I reduce the number of falls, I reduce the VTE rates, I reduce the VAT rates. Sepsis is horrible. It's a horrible, horrible thing to happen to you in a hospital, right? So if you can reduce sepsis in any meaningful way, it's worth so much, especially in the ICU. So to the physicians, this meant. Okay. We were in the middle of doing this just for the Ottawa Hospital. The government came along and said, and I'm gonna shorten the story a little bit. So it was gonna cost us over $100 million. We didn't know exactly how much, but over a 10-year period. They actually looked at it and they said, wait a minute, there's 32 hospitals out of the 140 today in 2016 that are actually going to go to procurement for a new HIS system. We're gonna get bankrupt. So the ministry basically came down and said, stop. No one is buying any big enterprise system on their own. You have to partner with others. These systems are made for multiple users and multiple organizations. So you cannot buy one on your own. So they stopped the whole project. We were in the middle of issuing our RFP, and they stopped it. And so we said, okay, who are we gonna partner with, right? So we did a landscape review. I won't bore you with that, but all of Ontario, we said, what's happening? How are partnerships working? What's going on? There's a partnership in the north in Sudbury. London had a Cerner partnership. The north had a Meditech partnership. There was one in Toronto. There was the one in Ottawa already with the Meditech partnership. So we just looked at our region of 20 hospitals. We said, what's happening here? So you can see they called it the CHAMP partnership. So there was 6 organizations, but the rest of them were all on their own. So remember I talked about the LIN, and we went to the LIN and we said, okay, who wants to join us? And 4 organizations put up their hand and said, we're in, especially if you're paying. Which we said, listen, if we're gonna pay anyway and you don't have to, we will cover your implementation portions. You can play ongoing, but we'll cover your implementation. That was the best decision our CEO made at the time. Hardest decision for him because our CFO was like, you're gonna what? Right? But he was a visionary. He knew the value this would bring to the whole region and to the 1.4 million people in Ottawa and the region. So he was very adamant that we would cover the costs. So these were the 4 organizations that joined, and very quickly afterwards, a very key organization said that they would also join, which was the Family Health Team. That's important because that's the first time that a primary care organization is going to use the same system as a tertiary care organization. So imagine if you went to your family doctor and they were using the same system as your hospital and all the information was shared, right? It's nirvana. For those patients that are going there, it was a beautiful thing. So they decided to join as well. We had some guiding, yeah, go ahead.
Do you think that, like, that's a great example of the hospital kind of driving change for the region? Do you think that's the future?
Yes.
Because I see it happen, like Trillium was where I was with,
Yes.
and they're doing that for Mississauga.
That's
It's
right.
like, we are partnered with everything, we want everyone connected to us, and
Long-term care, primary care, tertiary care, like, absolutely. Whether it's a hospital, I mean, hospitals are the big organizations in the region, so somebody has to drive change and drive, like, and take it on the chin, right? So by hosting this system, we're taking all the risk, right? But somebody has to. It has to start somewhere for it to get better. And I was lucky to have a CEO that was a visionary, and he said, "You got it, Shafiq, let's pay for it." I was like, "Great, you talk to the CFO, not me." We had to put some guiding principles in place in a partnership. How are we gonna work together, right? So this is the big problem in a partnership, is the small guy says, "Hey, I'm the small guy, I can't afford what you can afford, and, you know, you're gonna make all the decisions."
Let's take me out.
Yeah, that's right. Like, you know, I'm not gonna get a say in any of this, right? That's why they don't join, because they're independent organizations, they have their own boards. They can't go to the board and say, "We have to do this because TOH wants us to," right? Remember when I said the system is built this way? The system is built this way. It's built so that everybody acts independently, right? You have to take a risk to sort of break down those barriers. And the risk was, we gave everyone a say, right? And we were very transparent and said, look, we spent about 6 months trying to figure out what's your cost versus what's our cost. And if you're like me, analytical, you would say, okay, how much do you use? How many beds do you have? How many orders do you have? How many patients do you see? How many, you know, emerge? Like, you figure out all these components. It took us 6 months, and we came up with a formula that pretty much only AI could figure out, right? And there was no AI when we did this.
The first one is partnering with this other organization, has it changed like the initial CCO analysis and like the implementation?
Great question, really good question. If we had not paid for the implementation, our cost would have been lower, right? As it was, their costs were less than half of what it would have been had they done it by themselves. First of all, they could not have ever afforded Epic, right? Second of all, even if they bought something cheaper, it was still half that cost by joining a large organization. And they got it, when they joined, by the time they went live, they got it in 2 years. It would have taken them 5. Because they would have had to go through this whole TCL. All the things we did, they bypassed it all because we gave it.
Right? Like they benefited, how about
We benefited because 100% of our transfers come from these hospitals. Right? That's where you gotta get to. You gotta get down to the patient level, and then you realize, now, this is the start. Today, there's 10 hospitals that use the system. By next year, there's gonna be 18. Right, so we started something that snowballed. And now every patient is gonna have every part of their record from that whole region in one place. Very powerful stuff, very inspirational. We had to have some principles, i.e., the biggest issue in healthcare is siloed thinking, right? So a surgeon will say, I do surgeries this way, this is the equipment that I want, and this is the way I do it. The next surgeon doing the same surgery, totally different, right?
Yes,
Right?
yes.
And every doctor thinks that their way is the best way. So one of the reasons we chose Epic is they come with best practice workflows built in. So what we said is we're gonna inherit the best practice workflows, and unless you can show one of two things. One is that workflow has a safety hazard for your patient. One. Or two, that your workflow has a better outcome for the patient based on data versus what we can show with best practice. Unless one of those two things is true, you have to adapt what we tell you. We will change it if you can show us one of those things. Then we'll be happy to change it, right? Because it's a safety issue or outcomes for patients are better. That was 3 months of negotiation just to get to that principle. Remember I talked about why things take so long in public sector? Because you have to negotiate all these things up front. I won't go through a lot of the other ones, but we needed these guiding principles to figure out what we do. One of the things I didn't talk about here, I talked about the complex formula we came up with in terms of number of labs, number of beds, number of patients seen, number of emerge visits, I'll get to you in a second. This is the power of working with like very cool people and partnerships. It was actually the CFO of Hawkesbury, one of our partners, came back and said, listen, Shafiq, you're gonna need 3 people just to maintain this formula and figure out all those components from each of the hospitals to figure out at the end of the year where the money goes and how much. And in the end, it's not gonna make that big of a difference. He came back and he said, listen, why don't you take all of our revenue as all the organizations, add up all the revenue, and whatever my portion of that total is, that's how much it's worth. Very simple. He said, the way it helps me is it's predictable. I know what my revenue is gonna be at the end of the year, pretty close, because I have a budget. And so I know what my Epic cost is gonna be. And so he came up with a very simple, and you know what? We compared the two, and it was within 0.2% at the end of the day, right? Really simple and predictable. Very important CFOs, simple and predictable. If you give a formula to a CFO that's not predictable, and they don't know what the cost is gonna be by the end of the year, they will resist. They will resist and they will push back because they're accountable for the numbers, and if they don't know what the numbers are gonna be, they're in trouble. We went through what's called an RFSQ process, request for supplier qualification. And what we wanted to do through that process is take 10 people and get it down to 3. And it turned out we actually got it down to 2. Very complex set of, because now we have 5 organizations actually reviewing all of the requirements. It has to be right for tertiary care, trauma center, community hospital, heart specialist hospital, primary care hospital. All of these requirements are going into the RFP. So it became very complex. We had executive summaries, we looked at client references, there was a whole bunch of things that were included as part of the RFP. Here's what I heard from doctors. Shafiq, why are you going through all this? You're gonna buy the cheapest solution anyway. That's what we do in healthcare. We go through all this whole process, finance comes along and says, buy the cheapest one, I don't care about anything else, right? So we were really deliberate in saying, okay, we're not gonna focus on the money only. Money's important. I talked about TCO, and the whole first part of the presentation was about money, right? It is important, but when it comes to the doctors getting what they need, you have to consider clinical workflow and patient outcomes. And so we focused a lot on that. And in fact, when we came, and remember, I'm the CIO, so the technology should be the most important thing for me, right? We made sure that it wasn't, right? 6.5% on technology. Clinical was half of the evaluation. We had 1,200 clinicians sit through 3 days of presentations from 2 vendors. Evaluating, and we did this on paper specifically so that we could collect all of them, we could take attendance, and we put it, when we made a book out of it, just to show that this was a transparent, clean process. The ability to partner, all of those things, I talked about that, and then the finance piece was 20% of the evaluation. This is what got buy-in from the clinicians. They said, if you're gonna consider clinical value as 50% of the valuation, we're in. Getting 1,200 clinicians together in one place for 3 days, that was a monumental task in itself. And, yeah, and expensive. Actually, they did it on their own time. Yeah. It was not important to them. So we chose Epic. Here's some of the reasons why. Cool system. If you looked at the top 20 organizations in North America, 19 of them used Epic. 3 years later, 20 out of 20 used Epic. It had the best inpatient based on the class. If you haven't heard of CLASS, it's a good organization to look at. It's basically a benchmarking organization. This was one of the reasons they came with a prescription. They said, thou shalt do it our way. This is the way. We're gonna do this first, this second, this third. There's no variation. Best thing for a CIO, right? The vendor driving the process. Because otherwise, you talk to anyone who's done a Cerner implementation, man, oh man, it goes off the rails. Because the vendor will come to you and say, how would you like to do it? And of course, you've never done this before. They've done 400 of them. They should be saying, this is how you should do it for the best outcome. But they don't, because they know, if they ask you, you're gonna say, well, let's do it this way. Cha-ching, cha-ching, cha-ching. Beware of vendors who say, we'll do it however you want us to do it. Governance. Probably the second most important item besides money is how are you going to implement it? How are you going to make decisions? If one person wants this drug instead of that drug to be part of the order set, how are you going to decide? So you need a whole governance process. So we put together a governance process. Over time, it got very, very complex, but important. Let me go back to this. So one of the problems that we had was we were 80% of the total cost. Okay, everyone else said, okay, everyone's vote should be equal, and we said, wait a minute. If we're paying 80%, right? We can't have an equal vote for everybody else. Right? That doesn't make sense. So here's where we landed. Where we landed was, for a decision to go forward, it had to be TOH plus at least one other organization. So as long as they didn't collude and we all got together against TOH, we were good. But also, it couldn't come out that they all wanted something small that was too expensive or too menial for TOH, and we had to do it. So it was a balancing act, and we got all the CEOs to agree, TOH +1. That's how we move forward. Equity does not mean equal. Here's all the systems, modules of Epic that we bought. It is a very, very comprehensive system. What I should have put is put this in the same circle that I put it at the beginning, showing you all the components, but suffice to say, it has all the components that we wanted to do. We went live in June 1st, 2019 at 4 a.m. It was scheduled. We flipped the switch and nothing happened. Scariest day of my life.
That I've been waiting for the time to go live.
Yes.
What I want to ask, you said the process took 2 years.
Yes.
To implement and go live this particular.
Yeah.
Okay. When you are about to start implementing, I want to understand what process do you put in between your old process and the new process?
Oh, great.
How do you integrate that for you to have a seamless transition?
Oh, that's a really good question. The way it works in most hospitals is you always have a paper process. There's always boxes that are nailed to the wall, and you go to the boxes and get all your forms and start doing things on paper and phone people, right? That's, if the system goes down or if there's a power outage, this is kind of where you have to fall, because patients need care. So we have that as our backup. What we did was we individually tested each module separately from old to new. Yeah.
Tested each module.
We have our own test system, non-production, and we got a whole bunch of physicians and clinicians and nurses and everybody else to test it with us. And we said, okay, if we switch, how does it work? We tested it. It was over a weekend, it was at nighttime, we didn't care, we paid them, we bought them pizza, it worked.
Okay, it didn't work, you return back to the board.
It-
Okay, so what is your backup process for this if should in case it went bad?
So what we had said was at 6 a.m., so from 4 to 6, we would evaluate if there were some pieces that weren't working. We had a procedure laid out saying, okay, we call them P1, P2, P3. So P1 would be like very high, critical, emergency, not lab, but PACS, which is imaging. So emergency, imaging, and there was one more, I can't remember what it was. Something like that, I can't remember what it was. So if one of those systems wasn't working, we would stop. But if those three were working, then we would evaluate P2, right? So inpatient is P2, and then P3 was outpatient. Okay, generally speaking. And then we had our flow maps, and then we would just open the book saying, okay, where are we? Well, we're here, it says go. Everybody okay? Because the whole senior management team is right there. Here's our flow that we all agreed to before we went live. This is where we are. Everyone okay? So yeah, you have to have those plans.
Excellent.
Yes.
How did you decide on the date?
It really backwards from when we could start, i.e. when all the clinicians were available. We got lucky because June happens to be during the summer months. We needed 1,200 people on site at the elbow support. So we trained 1,200 people before. Just before this, I had to train everybody. And if you actually think about the logistics of training 10,000 people in 6 weeks, so I had to commandeer 64 of the 80 conference rooms across our 3 campuses. And the amount of hate mail that I got, just because I took away conference rooms from physicians who needed those conference rooms to do their teaching or their research. Oh my God, I think there was pictures of me on dartboards, people throwing things. Anyway, you can see the numbers there. 18,000 users across 5 organizations went live at the same time, 1,200 at TOH and 200 other at the elbow support, making a total of 1,500. And then every day, we called it the top 10 at 10. Top 10, what are the top 10 issues? And we had an open video conference with everybody, where we would just say, here's what's going on, here's what we know about, and we're still going ahead. We had the lab interface didn't work, so all the orders for labs were done on paper, results were coming back on paper. That was the hardest part that we went through. And the story with the lab is that the system that they were using in test was different than the system that was in production.
Yes, always.
That's like IT 101.
Yeah.
I didn't miss that.
I have, to this day, I have no idea how we missed it. It was actually the vendor-driven system, so when we said take a copy of production and put it in, they did that for us. But it was incorrectly done. So, it was brutal, it was brutal. Okay,
Oh, sorry, Shafiq,
yes.
before you move, those 1,400 at the elbow,
Yes.
were any of those co-op students?
Yes.
Oh,
Oh, in fact, most of them were still co-op.
okay. Okay, thanks.
This was, you haven't, I don't know if you've covered MRAM yet. MRAM is the EMR adoption model put out by HIMSS. It basically is a measure of the amount of IT you use in your hospital to provide value. Generally speaking, that's what it means. So, it's an 8-point scale, goes from 0 to 7. Most of Canada at this time, like around this was around 2016, 2018 maybe, around there. Most of Canada fell between a 2 and a 4. The Ottawa Hospital, remember, iPads at the bedside, we were at 1.8. Okay, so the minute we turned it on, we went to a 6. That is top 1% in the country. So why would we do this? This is why, right? Because it's a measure of the value you bring in healthcare using technology. This curve is pretty much the same. It's maybe moved a little bit to the right since 2018, but not that far. You would be very surprised. We thrived in COVID, right? So this is 2019, we went live, right? COVID happened right up. We absolutely thrived in COVID. We went from virtually 0% virtual visits to the ambulatory care centers to 85% virtual visits in 2 weeks. There's no way in hell we would have been able to do that. So somebody asked about value and what happens if you don't do this? We would have been absolutely dead. Analytics, long-term care. Do you remember during COVID, long-term care was the first hit? In Ottawa, we were taking care of our long-term care patients right with Epic, because we put Epic in a box and put it right in there, right in their center. We did that in 3 weeks. This was our journey. I talked about sort of 2014, where it was an inkling in somebody's brain that said, hey, everybody in the market that's top 10 is moving this way. How do we get there? What's our 21-month implementation cycle? What does go live look like? How do we? And then we started measuring, okay, what are we getting, right? We started looking at, there's a system called Care Everywhere. Epic has something called Care Everywhere. And what that does is, if you open it up, anyone else who's using Epic in your region, in your country, actually connects to you automatically. And so if a patient moves from your hospital to one of their hospitals, all that other information is automatically provided. And we turned it on, and within a month, over 500,000 patient information studies were changed hands. In 1 month, right? imagine the demand, right, that was there that we didn't even know. I had no clue that, you know, with the Kids Health Alliance and Sick Kids in Chio, St. Joe's Hamilton, there was patient information between Ottawa and St. Joe's Hamilton, patients, and not just a few, right? Like that's 7,000 in a month. Who knew? We didn't even know until we turned this on, right? Here's a view, like if you could actually turn this on globally, right? So we just turned it on for Canada, and the privacy people can tell you why we just did it for Canada. But if we wanted to, we could turn it on for the rest of the world, and all of the information would be shared across the world. I won't spend a lot of time here, but we went into, this is something I'm actually really proud of. Yes, go ahead.
So I have two questions.
Sure.
I want to understand the process of you actually settling for Epic. What were the, should I say, cons of the problems that you envision that you have with Epic as opposed to the other products, the negative and others? And if there were going to be maybe reasons for improvements depending on those ones, who was going to cover it? Were you thinking of, oh, we're going to opt for another product, or we're going to try to update like that system, work out something with Epic? What's that process like?
So are you asking like how we chose Epic over anything else?
Yeah.
Okay. So that was the 4 or 5 pieces. Like clinical workflows was number 1. Understanding when a patient goes from surgery to, you know, post-surgery to an inpatient bed, like that process is actually very complex. And in our current system, the handoffs between workflows, each one of them is a different department. They get a patient, they do their thing, and then they send it. Right? We've done our job. Yeah, this patient, surgery's done. They actually don't know what's happening in post-surgery packing. They have no clue. And then when they go to the inpatient and they're being taken care of, they have no clue. You would, by this day and age, but if you go to a hospital, you will see, you get passed on from one department to another. And you go to the emerge, same thing. They have no clue what's going on in the rest of the hospital. They're just dealing with trauma in and out, in and out, in and out. And they're overwhelmed. And the patient has to leave so the bed is opened up so that this patient that's sitting in the emerge that needs a bed can go to bed. So those transitions of care, as we call them, were very difficult. So that was like, that's one example. Paper, getting rid of paper, making everything electronic. Having the one-touch capability to have all patient information available. In our old system, you had to go to 3 different systems to get a full view of what the patient goes through. Radiology, labs, blood work, inpatient medications, all of those things were different places. So that was the clinical piece. Technology, what's the view for the future? Are they moving to the cloud? Are they going to implement AI? So you have to ask all of these questions to vendors, and then you evaluate. Clinical workflow, technology, price, and a few others.
So did you envision problems with Epic, say in the next 5 years or the next 10 years?
Yeah, we knew that it wasn't 100%. Like number 1, it's a US system. Right? It's based on billing. It's the number 1 issue. Everything is centered around billing. It was great for our docs. Their revenues went up immediately because they captured everything that they are doing with the patient that they used to do on cards. And remember at the end of the day, oh yeah, I ordered this for that patient. They used to do that on paper. Right? Now it's all done for them in the system, and all of a sudden, about 20% increase in revenue. Imagine if your salary went up 20% just by putting in the system. They would have been jumping up for joy. Obviously, I couldn't say that because I don't know. I didn't know at the time. I did. But there was some, US workflows that we needed to change. And so we worked with Epic to Canadianize the system. That was probably the biggest issue with Epic, is Canadianization. 'Cause remember, not that many Canadian hospitals were using Epic at the time. But now there's lots.
So this, my second question is more to you and the hospital itself. Because you mentioned that you had a background in mechanical engineering.
Yes.
And you're speaking about it now, it's more simplifying.
Yes.
I don't want to imagine what
Sure.
you being in that system at that point. So what did you do to know that, or needed to be able to see that this project in very intrinsic details? Okay, we need to work this out. We need to do this. How did you not miss out on something? Did you have maybe another degree, or you had to learn on the job? What was it?
Yeah, it takes a village. Like, it really does take a village. You cannot do this yourself. I had a team of 11 people internally that had expertise in all of the areas. This was my core team. And then I had consultants. I had 3 different companies that would provide consulting expertise. TCO, clinical workflows, implementations. So, and then the vendor helps you, right? Once you select a vendor, they help you to understand, well, this is important, this is not important. I actually I visited 17 different hospitals across North America and asked them the question. And there was one hospital I'll never forget, it was in New York. I think it was Sinai, Mount Sinai in New York. The CIO I spoke to, he said, I have 17 hospitals that I am the CIO for. 11 of them are Epic and 6 of them are Cerner. And I said, okay, great, because we're down to 2. Which one should I choose? He said, let me put it to you in a very simple way. He actually opened his drawer and he showed me both contracts. And he said, this is my Epic contract. It was pristine, clean, it was like he'd never looked at it. His Cerner contract, it had yellow stickies, it was frayed at the edges, it was massive. He probably looked at it every week. There was a message in there for me. Right? So it's just, you gotta talk to as many people who've already done this before. So that's just an example. So clinical, support, technology, it's just part for the job. And if you think you can do it yourself, you're wrong.
This is actually sort of a question, but you mentioned that there were already like some machines in place.
Yes.
Dating back about 25 to 35
Yeah.
years.
Yeah.
When Epic came around to do their job, was there like any bits of it that maybe repurposed or to like utilize?
That's a really good question. I would say less than 10%.
Because they were usable?
Yeah. We were able to use a lot of the lab systems because there hasn't been too many upgrades in lab systems over the last little while. So mostly it was around lab. I can't remember what else, but my guess was around 10% use, 90% was through away.
Will that account for the 2.9 million added to the budget?
I forget how much money that was, but actually we didn't show it anywhere. We just subtracted it from the price so that we could show a lower price. All right, I got about 2 minutes left. So we did a lot of work on clinical. We got it back, because I talked to you about technology. This is not a technology project, right? I am the CIO, so it makes sense I'm talking about technology. At the end, it's all about patients. How are we going? This, like if I had known this would have been all I needed to know. We reduced medication errors, right? By 65%. That's insane. This is people's lives we're talking about, right? This is the VP of Quality and Safety actually showed me this data. I was like, well, you should have told me this right at the beginning. But But yeah, it saves lives, it improves healthcare. Technology, if you enable it properly, will do that for you.
So before you're saying something I'm really proud of, but you didn't finish your sentence. I was just curious.
Say that again?
So before you said that I'm really proud of this.
Oh, yes.
and you're-
Thank you. Thank you. Okay. Before we did this project, if a patient wanted to see their record, what would they have to do? They would have to come to campus, line up, pay $5
Yeah.
to get a
Print.
photocopy.
Print.
That would take a half an hour, because the person had to go to each of the departments to get the photocopies made. And you had to go to health records, okay? About 5,000 people per year did that at our hospital. When we went live with something called MyChart. Many of you may know it. Basically, it gives you your record online. 250,000 people started using it on day one, right? This is something that I'm probably the most proudest of, is I'm giving healthcare back to the patient. Because if they're looking at their record, that means they're involved in their own care. If they don't see, it's like, doctor, tell me what I have to do, right? It's now up to 500,000 patients. So very, very, very proud of it. I could go on and on with the clinical pieces, need for change. We did this, right? We did this. And I was very proud to go back to the board and say, hey, you remember when I told you? I'll leave you with the change. Change is hard, right? I had a chocolate slide. Chocolate fixes a lot of things. It can't change. Can't fix it. This is a standard change slide that you will see in your change management courses. It talks about sort of that initial anxiety, then you go live, and it's like happiness, and then people started looking at, oh my God, oh my God, oh my God, and there's this valley of despair that happens. That's usually when CIOs get fired. I stayed through that, luckily. But then there's general acceptance and we can move on. We actually did an analysis of satisfaction for physicians and nurses over the time frame of when we implemented Epic. So you can see their satisfaction rates. Fusion was our project name. So we went live, and June 2020 is an important date. Even during COVID, satisfaction rates went up, right? Imagine what it would have been without COVID, right? So it's eerie how that is exactly the same curve as this one, right? Lots of lessons learned. I'm gonna leave you with, this is complex. This is all the systems that Epic interfaces with today. Okay, we're not done. There's more to do, right? This is why the IT team is pretty big at the Owl Hospital, because somebody's got to manage all this, right? And when Epic has an upgrade, we got to test all of these individually, because otherwise people get hurt.